So can we start? It's 8 o'clock.
Yeah, go ahead.
Good evening, everybody. On behalf of the Endocrine Society of Bengal, I welcome all of you again to the Electronic Endocrine Enrichment by Experts, the 4E webinar. For today's topic, we have an important topic, that is thyroiditis. And to chair today's session, we have Dr. Saptarshi Bhattacharya, sir. Sir is a senior consultant and head of the Department of Endocrinology in Max Superspeciality Hospital, Delhi. I had the pleasure of working with Sir for the ESI research workshop module, which has been going on, which is due to end next week. And Sir has been ever encouraging to all the postdoctoral trainees and the senior residents to actively participate in academics. Thank you, Sir, for spending time to join our today's session.
Thank you.
And as a speaker, we have none other than Dr. Mohan T. Shenoy, sir, from God's own country, also my home state. Sir is a consultant endocrinologist in Sree Gokulam Medical College, Venjaramoodu in Trivandrum. Sir is again, he's in charge of the Twitter handle of ESI and always encouraging us and to participate in all the webinars which have been going on for the past 1.5 years. Again, I'm sure he's already made an extensive presentation for all of you to enjoy in today's session. Sir, again, thank you for accepting our invitation to take part in today's program. Saptarshi, sir, you can take over, sir.
Okay. So thank you, Rahul. So I would first like to thank Dr. Nilanjan, Dr. Shamik, Dr. Rahul for inviting me to this meeting. So
oh, sorry.
Am I audible now?
Yeah.
So I would like to thank, first of all, the Endocrine Society of Bengal, Dr. Nilanjan, Dr. Shamik, Dr. Rahul for inviting me to this meeting. And I would like to congratulate them for successfully organizing such an academic event for I think almost for last 3-4 months. They had almost 10-15 sessions, and it's being accepted and acknowledged all over the country. So we have a very important topic today, which is thyroiditis. So I think we use the two terms, thyrotoxicosis and hyperthyroidism, often interchangeably, which is a wrong concept. So these are two different entities, and if the postgraduate students and the DM students are able to, and the treating physicians, they're able to differentiate between the difference between hyperthyroidism and thyrotoxicosis. So I think half the case is already done. So these are very important concepts, and Dr. Mohan Shenoy will be presenting today about thyroiditis, which comes under thyrotoxicosis, but actually per se does not come under hyperthyroidism. I'm quite sure Dr. Mohan will throw light on all these aspects, and I won't take any more time. Over to Dr. Mohan for his lecture. Thank you.
Thank you. I'll just take the time to share the screen. Thank you, Nilanjan sir. Thank you, whole Endocrine Society of Bengal, for giving me the opportunity. Thank you, Saptarshi sir, for the words. So I'll go for the PowerPoint. Yes. So hope I am clear. My sound is also okay, and my screen is visible. Rahul?
Yes, sir. Yes, sir.
Thank you. So yeah. So thank you for the opportunity. Good evening, everybody. So I will discuss the topic basically on the 3 headings. So we'll have a case as an introduction, and we'll go for how we'll arrive at the diagnosis of thyroiditis and arrive at the various differential diagnosis of this condition as well. So as you know, it's an umbrella term. It's a conglomerate of various conditions put together. And how about the management, and why we have to go for the strict guideline-based practice sometimes, and some practical tips, because I understand that we are in the webinar era. So I think it's not a take-home messages which I want to give you. It's a practical tips and whatever we have learning through this modern books and the literature. So as you know, the thyroid hormone is a major hormone, and it is a master of the metabolism. It is unique among the endocrine glands because it has a vast amount of thyroid stored and releases very slowly as such. So you know the metabolism, but just to show you that thyroid is composed of follicles surrounded by a single layer of epithelial cells called follicular cell. The follicle absorbs iodine, as you know, and it is stored inside it is stored in the thyroglobulin as a glycoprotein. And you know that active uptake of the circulating iodine to the cytosol is by sodium iodine symporter. Secondly, oxidation of iodine by thyroid peroxidase, and then iodination of tyrosine residues, creating mono and diiodothyroxinases. So finally, the circulating T4 and T3. So I wanted to put just a light on how this metabolism initially occurs. So thyroid hormones are very active. We know that T4 is the one which is more in quantity, but T3 is biologically active. I'll just take the pointer. Yeah. So you can see that T3 is more potent, but T4 is the one more available. You know that the hypothalamus, pituitary, and thyroid, they got an axis in itself. So T3, T4 produced gets a negative feedback on the pituitary as well as the hypothalamus. So there is also a role for the other releasing hormones and the TSH signaling. So again, a basic biochemistry brush up for you. So T4 is the more we are seeing circulation, and it is actually the more produced, but potent one is T3. And half-life of T4 is more, that is, we know that levothyroxine has the almost a similar half-life, which is the physiological form, which is about 6.7 days or 1 week approximately, and T3 is only having 0.75 days. And you know that the fraction secreted by thyroid is actually 1, another one is only 0.2. That is in the final bioavailability. So coming to the case, it is a thank you to my colleague, Dr. Ronnie Rubin, for sharing this. We have got a Endocrine Society of Kerala by also having a good amount of case discussions. So this was presented by him in one of the webinar series. So I am glad that he shared this with me. So this is a person who was working as an executive, is a female, presented with features of fatigue, neck pain, tremors of the hands, and palpitation. The clear-cut diagnosis was not made outside. They had been treated with a short course of antibiotics at the one-day fever itself. And you know that antipyretics, antihistamines were also being given for the upper respiratory tract infection. When she came to us, she had no fever, only she had fatigue, neck pain, and tremors. This is the importance of the history taking. So in this COVID pandemic, as you know, Kerala is having a lot of cases reported. We are actually prone to doing this test. So we have done the SARS-CoV-2, it is negative. I will also tell about this in the another case which I'm going to present. So a known hypertensive dyslipidemia on cilindipine 10 mg OD and also occasionally using. So she tells that she uses alternate days, alternate weeks. So not very religiously following the statin, but she has family history of diabetes, dyslipidemia, and cardiovascular disease. So importantly, another history is that she has born 2 children, no past history of any thyroid illnesses. So she's afebrile, anxious, but you know that she's very cooperative. And the thyroid swelling is also very obvious. It is tender and very firm in consistency. So whether we do it always, it's very important. Despite the COVID times, we have to insist on limited examination. And one of the signs we look for is the skin signs and the eye changes, which is not there. And history also, we have seen that she's having the pain. So it is very tender to touch as well. So blood pressure is coming to the borderline. She's already having hypertension. She's not taking regularly that also. And we are seeing that she's having pulse rate of 92 per minute. It's regular. So she's having tachycardia and she's fine tremors. So we think that it can be hyperthyroidism. So coming to the full picture, we always rule out non-thyroidal neck pain also when in the history taking. So I understand that we have got postgraduates and also trainees as well. So for them, we just got one slide regarding the non-thyroidal causes of neck pain, because I'm sure that you will be going into exams as well. So these are the common causes which you usually have to rule out. And for the completion's sake, we also have to remember that there is also a condition called globus hystericus, or a hysterical patient just telling pain. These are the complete list of non-thyroidal neck pain. I refer to the textbook of Das. We know that is the Bible of surgical graduates as well. These are various causes. These are not there in this patient. Cervical lymph nodes may also be the reason. So even these conditions have to be considered. So laboratory, to complete the laboratory, we can see that hemoglobin is okay. Total count is a mild elevation. And we can see it's more of neutrophilia and lymphocytes 24. ESR comes to be a bit high. We have a cutoff of 20 for our lab, so it is above the range. CRPs come negative. And you can see that because maybe she has received antibiotic, that may be one of the reasons for this condition. So TSH is low, suppressed, T4 is high, and T3 is also high. So the Dr. Ronnie has told that anti-TPO, anti-TG were done and it is negative. The values are very low, which is why I have not put them in this slide. So to rule out diabetes, we also checked RBS, it is 102. Other tests were not significant. So whenever you have a low TSH, we go for imaging, which was done in this case, and that showed very low uptake. There is actually negligible uptake in the neck. Usually the salivary gland consistency we compare, so there is no uptake in the thyroid region. We also found out that it is a homogeneous. We can see that it is a diffuse echogenicity and it is suggestive of thyroiditis. So this is what the patient comes up, but the antibodies are negative. So I will come back to the case after a bit of introduction to the topic. So you know that normal thyroid gland has got two lobes, and basically the biochemistry has to go in with the structural aspect also. So we know that the availability of the thyroid nodules also increases the secretion. So this case, there was no nodules in this patient. So we live in a country where iron deficiency is still prevalent, and iron we are trying to address by various sources, iron salt and various other ways. So we know that goitrogens are also there in our diet. So these are all the factors which we consider in the pathophysiologic aspect. So diffuse goiter may be the reason in some populations because of these two conditions. But we know that once these perpetuation of all these environmental factors and other factors, there can be leading to repeated episodes of hyperplasia and involution. So these lead to the formation of nodular goiter. So this is a general pathway of the thyroid and the nodule pathway. So Dr. Saptarshi briefly alluded to the thyrotoxicosis and hyperthyroidism. Thyrotoxicosis is the clinical state, whereas hyperthyroidism is due to the inappropriately high synthesis by the thyroid itself. So it is more important in our practice. So coming to thyroiditis. So thyroiditis, as you told, it's a very much a diverse group of disorders. They are characterized by some form of thyroid inflammation. So we know the appendicitis, so many conditions. We are used to having Google generation. So people just find out they have thyroiditis. They come up to us very frequently. Doctor, please see that whether my inflammation is gone away. So that can be the case in subacute cases, but more often the hypothyroidism can be part because of the chronic inflammatory pathways. So there is also some controversy regarding nomenclature of various types. So I am trying to get a non-controversial classifications done. So most of thyroidologists use the term subacute for a specific condition of subacute granulomatous thyroiditis. So we know that infectious thyroiditis also is one of the other causes. It's also known as suppurative thyroiditis. Some painless thyroiditis are often silent. These are also to be understood that they can also be more frequent. Then we also have a spontaneously resolving hyperthyroidism, sometimes seen in a Hashimoto thyroiditis or lymphocytic thyroiditis. Hashimototoxicosis. So this is a main prototype, which is the autoimmune thyroid diseases. Nowadays, they are described as the major cause of hypothyroidism because we are seeing that sufficient iodine intake is seen in our population. So it is the most prevalent thyroid disease in our area of the world. It is a multifactorial disease. So autoimmunity against the thyroid antigens develops against a particular genetic background. And I am taking it from Williams. So they have mentioned that it is facilitated by the exposure to environmental factors. So we always remember that environmental disruptors can also be there. So even if we don't find the trigger event, it can be found out as we go through the time. It may not be found also. It may be idiopathic as well. So Werner Ingvar is one of the book which we referred to. They have described that as a result of immune cells response to thyroid antigens. So this is the most important cause in our own autoimmune diseases. Thyroid autoimmunity is one of the major common problems. So age group is also typical. The sex ratio is more for females. In some conditions, actually, it may be part of a cluster, and we describe it as a polyautoimmunity or hereditary syndromes. So I will just take 1 minute about the Hashimoto thyroiditis. It was initially described by scientist Akuro Hashimoto in 1880s, and we know that we had a Hashimoto Day celebrated in May last year. So we also were continuing with various activities regarding this, but we remember that he described it as a struma lymphomatosa. And until 1950s, the description of antibodies was not done. So this is by the remarkable novel work by Deborah Doniak and Ivan Roy. So these have described the first antibodies were the thyroglobulin antibodies. So discovery of Hashimoto thyroiditis was a relief to scientists because previously they were thought that it was a horror autotoxicus. So which means that they were actually very much scared about this, and the surgeons were actually operating this without knowing the real reason for the condition. So once this were discovered, basically conservative management is more prevalent among these conditions. So classification is broadly into autoimmune. This can be focal or diffuse. Then comes to the infective, I already mentioned. So infective can be the acute ones, that is the bacterial or viral infections. Chronic infections like TB and syphilis are also described. I'll also tell you why actually thyroid is actually immune to many of these infections. Subacute thyroiditis, which may be the reason in our case. Then granulomatous or decurvent thyroiditis. Some authors describe intermixed with these two. That is why I have kept in a non-controversial way. Then comes to the fibrosing type or Riedl's thyroiditis, which may be part of other IgG4 conditions or polygranular syndromes. So again, the course of the disease, as I had told most of the often, the goitrous Hashimoto disease has got a chronic disease pattern, and features are characterized by goiter, lymphocytic infiltration. I told you about fibrosis because of the plasma cell, and also lymphocytes, and you can see that thyroid cell hyperplasia also as seen. So basically they also take time to resolve, so that they need not go for yearly biopsy as such. Then coming to atrophic thyroiditis, it is a primary variant. You can see that it is a chronic condition, and it is a atrophy and at older age, and it can lead to fibrosis as such. Then juvenile thyroiditis, it can chronically disappear. Then comes to the postpartum thyroiditis. It is transient in nature. It may progress to chronic and lead to hypothyroidism. It is classically seen in the 12th week postpartum, and you can see that it is sometime you can have a lymphocytic infiltration as well. Then comes the silent painless thyroiditis, characterized by a small goiter and only some amount of lymphocytic infiltration. So it's very difficult to clinically make out among the variations, which is why the scientists have come up with various other laboratory parameters. So coming to the focal thyroiditis, it is a progressive type, and it is seen in the thyroid gland in 20% of normal person also at biopsy, at the autopsy. So the painful thyroid DDs for the graduates would be the subacute will be the #1 cause. There are the other causes are also there. I just put it for information for all of you. Is the acute infectious thyroiditis, then coming to the acute hemorrhage into a cyst, acute hemorrhage into a benign or a malignant nodule. So rapidly enlarging thyroid carcinoma can also be part of a painful thyroid. Then a painful variation of Hashimoto thyroiditis is also been mentioned. Then coming to the rare causes like radiation thyroiditis, painful amiodarone-induced thyroiditis, and thyroid lymphoma. So I think this is a very important slide. Whenever you have a Viva, maybe at least 4 of the causes we have to be mugging up or memorizing. It's very easy to remember if you are going by the sequence. So again, the pathophysiology of all these conditions have been described. It's a very busy slide, but you can see the pathophysiology. The pathway is by the autoimmune antibodies, and relevant lymphocytic infiltrates are occurring, including the B and T cells in the thyroid tissue. The first event is believed to be the functional alteration of the B cells and the formation of autoantibodies. So autoantibodies formation leads to loss of the immune tolerance, so that the self cells are not recognized, and finally they lead to destruction of the thyrocytes. And the other variation is the Graves' disease. There is a B cells hyperstimulation, and finally you can see that the immune pathophysiology is not relapsing, and finally leads to a large storm-like condition in some conditions. So the Hashimoto thyroiditis is basically a very naive condition, and his hypothesis is that the cellular and humoral immunity are very important in this. pathophysiology. Finally, we can see the apoptosis of the thyrocytes is the end stage of Hashimoto, whereas Graves, unless we are properly managing or properly recognizing, they can lead to continuous phenomenon of recruitment of immune cells. So what are auto antibodies? So we can see that patients are coming to us they may not be a patient as such. They may come today. Also, we had a case coming just with the report of antibody without a TSH value or T4 value. So I just put this for the sake, because these antibodies are not harmful by themselves. They appear to be a secondary response to thyroid injury, and they are not causing disease by themselves, although they may lead to contribution to development and chronicity. So we can see that both types, that is anti-TG antibody and anti-TPO thyroid peroxidase, are polyclonal in nature. So they are immunoglobulin G in class and not restricted to a particular immunoglobulin subclass as such. So basically, they have got some transfer across placenta, but they are much the TRAB early is the most significant one, because they don't have any disease correlation. But they can have association with the miscarriage in the long run by the Negro et al. Studies. This is the diagram which shows you the thyroid follicle, the thyroid peroxidase in the beaded form, and we can see the inside, the thyroglobulin against which antibody can be formed, and finally the receptor antibody, which is seen in the Graves condition. So again, I have taken this from the Williams textbook to show you a beautiful description in which general population can also have autoimmune antibody positivity. So not to be worried, at least 5 to 20% have the TG antibody, and 88 to 27% have got TPO antibody positive. So there we can see that Graves' disease, more significant cell specific is the TSH receptor antibody. And we can see that other autoimmune conditions like type 1 diabetes also, we can see that TG antibody can be positive, but not the TSH receptor antibody. Again, normal pregnancy women can have 14% rate of positivity of TG antibody and TPO antibody. And relatives of patients, they also can be predisposed. So if you have one individual, need to screen, but maybe on annual checkup, you should do a follow-up. So again, the TSH receptor antibody, I'm just showing you regulated production of hormones are seen. So negative feedback control is there. Once the TSH receptor antibody is formed, we can see that the cells are unregulated overproduction can occur, leading to a condition which can lead to a storm-like situation. So we are just showing you the autoantibody association and comparison with Graves' disease in this picture. So this is taken from Nature Review Immunology, just to show you that thyroid antibody can have two different spectrum. So there are two opposite pathogenic process. During Hashimoto disease, you can see that autoreactive CD8 T cells are seen here. It is not seen in the Graves' disease. In Graves' disease, there is also the TSI or thyroid-specific immunoglobulins or thyroid-stimulating immunoglobulins which are formed, and they are previously called LATS or long-acting cells, and this lead to unrestrained thyroid hormone overproduction. Whereas in the other cell, we can see that consequences can lead to the necrosis, apoptosis, and finally the hypothyroidism can ensue. So completing the list, we have acute suppurative thyroiditis. So I had already told you, it is again a viva question. Protective mechanisms contributing to relative resistance of thyroid to infection. The major reasons are these things: rich blood supply to and lymphatic drainage, which is one of the major things, and high glandular content of iodine. Iodine may be considered as bactericidal. We know povidone iodine has been used. This is all hypothesis. Then separation of thyroid from other structures by different facial planes. So the thyroid fascia also are there. Then a protective capsule. You know that there is a true capsule. So this is a complete protective fibrous capsule surrounding the gland. So in contrast to major glands in the body, the thyroid gland is remarkably resistant. So very uncommonly we are seeing, this is from a textbook description I have shown this picture. So what are the routes of exposure? So these are the, again, for the main description sake, you can see the history taking, again, pyriform sinus fistulae, lymphatic or hematogenous spread, existing thyroid disease, infected branchial arch abnormalities, and you can see that neck trauma, fine needle aspiration biopsy done in untrained or even repeated hands, it can lead to all these routes of infection. So I have just again taken only the salient diagram from the Werner Ingvar textbook, which I consider as one of the best books in thyroid. not only me, many others are considering it. So the frequency is having a change because before 1983, about 40 years, we had seen that the conditions like syphilitic conditions were seen, fungal also were more, but now thankfully the conditions are rare. But we can see mycobacterial tuberculosis is continuing to be having 9% frequency and higher chance of the bacterial infections. Various bacterial infections have shown to have higher chance, and even parasites, which are also we'll be describing. So back to the case. So it's a case which has been managed. So we had done an uptake scan. So uptake scan is relevant because raised uptake can be seen in Graves' disease, toxic nodule, as well as in a toxic component of a multinodular goiter. Also sometimes in amiodarone thyroidotoxicity type 1. Then you can see that hyperthyroidism with a low uptake is seen in decurvents or subacute variant, and we can see that lymphocyte thyroid acute phase can have these conditions, and by other drugs as well as amiodarone type 2. Then coming to the rarest cases like struma ovary, by one case had picked up a metastatic thyroid carcinoma by doing the cold nodule also. So next half I will focus on the other relevant forms of thyroiditis, which comes to the pregnant woman and the woman in the childbearing age. This lady is 43-year-old, technically is coming to the reproductive age group still. So this is why this table is significant. So common causes are these. It is a Graves' disease again we are seeing, but this is thyrotoxicosis. Then postpartum. Then we are seeing transient gestational form, excessive because thyroid hormone. We had a case in Amrita when we were doing students. That time we had a patient who was not telling anything about this history. Unless we provoked, we finally landed with this. Because some patients have got these tricks in their bag. So maybe you should ask very, very carefully, and even then we may not come with this diagnosis. Uncommon causes are autonomous functioning thyroid nodules. And again, I had told you this is an uncommon cause, but I think now it is more common. It's painful subacute thyroiditis, and rare causes are seen as I had told previously. So subacute thyroiditis is a second common cause of hyperthyroidism after Graves. It is seen in females in the 4th to 5th decade. Preceding history of upper respiratory tract infection, because the viruses like Coxsackie, Echo, measles, mumps, even nowadays COVID also we are describing a preceding URTI positivity. So typically the T3, T4 extremely high, and it come back to normalcy after at least 4 to 6 weeks. Then you take anti-TPO and anti-TG, which are majority case normal, and immune destruction may be a part of the HLA-B35 association. The pathophysiology is a destructive release of preformed hormone. It is a painful gland tended to palpation. It is actually showing no radioiodine uptake or the technetium uptake in the gland, and its treatment is basically conservative. Given a choice, we don't give any drugs, but for pain we give non-steroidal anti-analgesic drugs as well as corticosteroids sometimes when the pain is severe. Also, in some cases of postpartum thyroiditis, we have a situation where we give this corticosteroids. Relapse is rare. Primarily, permanent hypothyroidism is a more possibility in 5 to 15% of cases. So again, a comparison between painful Hashimoto versus subacute thyroiditis. So fever is a variable component, and whereas usually is seen in subacute thyroiditis. ESR elevation, CRP is elevated in the subacute thyroiditis. As I had told you, the CRP was negative in this case, maybe because she had received antibiotics before. So prior thyroid disease is common, painful, and also family history, all we should screen. And corticosteroid response is very poor in Hashimoto thyroiditis. We actually discourage them, whereas there is a very good response in subacute thyroiditis. And antibody positivity is very good in this case, whereas it is usually absent in subacute thyroiditis. Sonography, I will take time to describe, but just to show you that diffuse heterogeneous echo texture with the increase. So sometimes fibrosis also can occur, Hertel cell changes and variable fibrosis in this case, whereas other subacute comps can have a non-descriptive diffuse hypogenicity, and sometimes, very rarely, we can have a granulomatous malformation and neutrophil like in giant cells also. So recovery is very important because it is the way the course of Hashimoto's can be variable. They can even lead to euthyroid or hypothyroid, whereas subacute thyroiditis are basically revert to euthyroid after this condition. So I promised you regarding a slideshow, and this is the ultrasound picture. We can see a diffuse micronodular pattern, and this can be mistaken because they have some areas of particular description, nodule-like presentation. This is by the thyroid regeneration. This is also known as a white knight, benign by definition. It's actually very benign. And also we can see in this case, we can see a lower paratracheal region, hypoechoic adenopathy. So this can just be having a reactive like nature. So this can having a mimicking nature. We may mistake it. So we have to have an experienced radiology with us. In Amrita, we do radiology ourselves. So that is why we used to do this per se. So we had some picture also. This is a micronodular pattern. We can see a pre-existing musculature comparison. So predominantly we are seeing a lymphocytic infiltration, and we can see a presence of the germinal centers, and we can see the Hertel-like oncocytic follicular cellularity. So which is why we should always ask the pathologist whenever they are unsure whether they have checked all these things in this regard. So also to show you a fibrous variant, so we have to check the echogenicity with the pre-thyroid musculature. This is seen here. So we are seeing comparison with this. So which is why we are seeing hypoechogenesis in this area. So this is totally showing you the fibrous band. So this area is the fibrous band. I hope you can appreciate. These are delimiting the follicular cell nodule. So this is having no the follicular cells in this case. So fibrous variant also has been to be considered in a Hashimoto condition. So the decurvent subacute, basically we don't go for an FNAC, but sometimes in some patients who had been FNAC before, this is the description. Some forms of granulomas have been described. So this is the picture which has been shown you, patchy hypoechogenicity. So color Doppler is one of the good tests which we can show in this regard. So routine follow-up of Hashimoto, also we can see a picture which has been showing a typical, almost similar to that of this subacute thyroiditis. So this is what this is showing here. So the nodules are not identified. So this is why a yearly follow-up is required in ultrasound for these conditions. So as I told you, in US literature, there have been descriptions of this condition called hashitoxicosis. I have only seen one case so far. So this is a case being described to show an overlap between the Hashimoto's and a toxic thyroid node. So we are seeing this case being initial picture showing uncertain picture, which is why we have to give a beta blocker initially. Always rule out bronchial asthma, because when these beta 2 blocker, Ciplar or propranolol, these can trigger the asthmatic episode. So this is why we should use other safe drugs. And in case uncertainty is there, they are also mentioning, the American College has also mentioned a short course of antithyroid drugs, because it is a bit controversial, which is why it is not a standard thing. But as it is a rare condition, we have to use our own clinical judgment in this case. So coming to the postpartum thyroiditis, so it is a subclinical hypothyroidism in 50% of anti-TPO positive women. So it is a transient destructive autoimmune phase seen in the 12th to 16th week postpartum. So again, this is again a theoretical thing, but very important practically as well, because post-delivery, they have a variable course. So some patients may have a silent Graves sometimes. This can be triggered post-delivery. We can see this is the pattern in this case, A. The second arrow you can see in B, you are seeing a transient Hashimoto thyroiditis. And third phase, which is the case of postpartum thyroiditis, it may be preceded by a thyrotoxicosis, but finally these can go into a permanent hypothyroidism. So it's a temporary, usually painless episode. It is characterized by a short preceding episode of hyperthyroidism. In 25% cases, they progress to a permanent hypothyroidism, and approximately 5 years' time is what they have mentioned, which is why antibody titers are very important in this regard. So again, I am taking a European Journal of Endocrinology description to show you in a nutshell the various pathophysiologies in pregnant women as well as in this postpartum delivery. So we can see that antibody levels are very important, and the estrogen state is the pregnancy, which is important because nodule formation, physiological, they can be goiter also. The TBG values are important in this case. So we can see during pregnancy, the trap antibodies can cross the placenta into the fetus, and the newborn infant can have a possibility to suffer from Graves' disease as such. So again, the postpartum thyroiditis, the cross-sectional ultrasound, we are seeing here that this is a clear-cut case, but we can see that unlike Hashimoto thyroiditis, there is an absence of fibrosis. So this is self-explanatory. We are seeing this absence of fibrosis, and also we are seeing a non-specific. A previous stain, you can see a typical, the stain was showing a different color, but this you can see it is a clearer picture. So it's an unspecific lymphocytic infiltrate, and you are seeing the normal follicular cells also in this case. So it is a very thing which we have to pick up by clinical and a good sonological tool. So finally, the renal thyroiditis, it is a very heterogeneous parenchyma. It is a firm to hard in consistency. It is a spectrum of IgG4 disease. It is a different topic by itself. And this is a very important thing because collagen is arranged in a short interlaced picture, and they are irregularly arranged as well. This is a CT picture showing you that the thyroid has enlarged, and a typical MCQ, it is a esteriform pattern. So it is a very important esteriform pattern. This is the one we are seeing, orange shadows, and it is a lymphocytic inflammatory pathway here. So it's an admixture of all these things, which is why it is rare as well. So just to show you that it is coming to the in an older age group also in these individuals, hypoechogenic and micronodular hyperechogenic, sometimes having a septation as well. So coming to the last case here. So it is a 41-year-old IT professional. Fortunate that education sir had shared this case with me. So this is the lady he had seen in his clinical picture. I'm sure you also had similar pictures in her. She was actually had a 8 weeks post-COVID, and she had a very bad COVID as well. Also, she was in the hospital for that, and given all the immunological agents, I will not tell everything. So we are seeing the thyroid picture. TSH is low, the T3 is high, but T4 is showing to normal value. Free T4 is normal. So in this picture, you can see that the thyroid shadow is also very uptake is low. So these are the pathophysiological mechanisms for the COVID and thyroid. The three effects of thyroid in the virus are: the first pattern is the thyrotoxicosis pattern. So it can be either the subacute painful thyroiditis or a painless atypical thyroiditis. Second part, it may be a typical straightforward case of hypothyroidism, central or primary. Both the central form, the pituitary form, or the primary cause are possible by the COVID-19 virus. So there is a direct action is also seen. Then comes to the third one, which I think is more seen because in the ICU patient, it is euthyroid sick syndrome or the non-thyroidal illness syndrome. But definitely, very good literature is coming up regarding the subacute painful thyroiditis as also. So in this case, we had this description of this review. We are fortunate that 2020 itself, we had the reviews available. This is the latest review for 2021, a systematic review from this journal. So a comprehensive analysis was done. Autopsy studies were also done. So this is showing that there is a direct evidence is there because ACE2 receptors are also seen in the thyroid cells. You can see here that this receptor having the TMP RSS2 in the thyroid cells. So I am saying that so many literatures are coming. I think COVID is going to teach us more and more with time. So again, a JCEM publication had shown subacute thyroiditis after the SARS-CoV-2 infection. And this is a very appreciated case report, and this is why I have put this. Again, I was fortunate to be associated with the research editor with my friend Karthik and Dr. Vikram. We had reported to the Thyroid Indian Journal Thyroid. We had seen 2 cases. So this is how we are able to report in our practice as well. So in a nutshell, the mechanisms of COVID is definitely likely having a structural proximity because the virus leaded superior airway, because the thyroid gland, you see protection is there, but the virus leaded the trachea, all these structures are very close to the thyroid. So they may have a chance for this. Again, the drugs used, there are various drugs used, not to forget the biotin, various nutraceuticals are using that. Then heparin is used for this DVT prophylaxis, and you are seeing monoclonal antibody. This patient had received these drugs. All these drugs were received. Again, non-thyroid illness, inflammation, sepsis, and steroid. If you have time, maybe you can take a screenshot because Unni sir has definitely permitted this for this case. So again, a case series have been reported regarding the drugs and thyroid. again, our very famous Dr. Shashank Joshi sir has reported way back in 2007. This is a publication in this JAPI journal, Drugs and Thyroid. Just to show you that amiodarone is one of the notorious drugs for this, because when we have a patient receiving this in our cardiac patient, sometimes we have ignoring that, but we should always see whether these are having. Cardiologists definitely refer to us, but sometimes we may not have this history always. So intrinsically, these are the mechanisms reported. We have seen a Wolff-Chaikoff effect because the sodium iodine importer, the negative effect on the organification of iodine, the failure to escape from the Wolff, we can know that amiodarone has got at least 50% above concentration of iodine. So this is the very important thing. Iodine-induced effects are seen. Iodine-induced potentiation of autoimmunity is also seen. That is why autoimmune disorders also are reported to be occurring. Again, patients with underlying autonomous nodules or latent thyroid disease having, this is also known as a job-based effect. Their intrinsic drug effect, because these drugs also inhibit the deiodinase enzyme. And again, the direct toxicity is also described in the destructive thyroiditis. So this is a very important pathophysiology. I'm sure you all be knowing this, but I thought this will be useful for you. So to compare these things in a one slide, again, I have tried to condense it. Autoimmune, that is amiodarone thyroiditis type 1 is basically the one which are hyperthyroidism by the iodine induced, or the one which is caused by the drug. And it is the one which is basically naive, and these are needed to be screened because they have got the diffuse or nodular goiter. As I had shown you, it is very difficult to make, which is why a Doppler or the ultrasound will may be useful. And I had told you that a technetium scan is very useful for this. Treatment is again antithyroid drugs in this case, but not for the autoimmune type 2, which is the destructive form of thyroid toxicosis, in which the flow is decreased or absent in ultrasound, and treatment is steroids. So this is the again the ultrasound picture which have been captured. So diffuse goiter is one of the things which we are seeing in the type 1. So this is what seeing in this case, and we are seeing the cross-sectional ultrasound showing microcalcification also. Sometimes patients are scared about this, but definitely when you are following up, they are very much benign. So again, amiodarone-induced thyroiditis can also be type 2, destructive or no uptake, which is definitely in most of the cases, and we are seeing hypothyroidism is what we are seeing. So in other cases also, we are seeing many other drugs like interferon alpha used for HCV and many other conditions. I'm sure you are being using most of these conditions in other cases like immunological drugs. Interleukin 2, the sunitinib or the kinase inhibitors, newer drugs like IMAPs or immunotherapy. We are seeing the implulimab, very difficult to pronounce as well, pembrolizumab. These drugs have got the CTLA4 and PD1 receptor action, which is why we should remember this table whenever, not to forget our friend lithium, because this is used in patients hyperthyroidism. So we are wanting to address that storm case also, but this is actually having a reverse case also, which can also associate with painless thyroiditis. Also, they can also lead to hyperthyroidism. So again, immunologicals, in one slide I thought I will mention interferon alpha is used in many conditions like multiple sclerosis, leukemias, renal cell carcinomas, HCV. So thyrovigilance is required in these cases whenever patients are, because 40% of these persons can develop antibody to thyroid and 15% can develop clinical disease. So these can have Graves-like presentation, painless thyroiditis. This is why history taking is very important. These are the mechanisms of action. Again, immune-mediated mechanisms are there and direct thyroid mechanisms are there. As any other drug, they cause triggering the immune response and expression of the cells are triggered. So this is an article which has come up recently regarding the pembrolizumab, which is to be recognized is one of the very much drugs used in metastatic lung adenocarcinomas. This can be because once these triggers are occurring, maybe the drug also needs to be stopped in some cases. But often they are very much self-resolving and very much benign. Some cases we are also seeing a post-radioiodine thyroiditis because we know this phenomenon of Wolff-Chaikoff effect. So many conditions are seeing. So atypical abundant cells of large pleomorphic, these are the things which we are seeing. description which are also common, because when patients have been receiving drugs in angiogram or some other conditions, we are doing contrast studies. Remember that these contain iodine content, and some agents like betadine, so many drugs used in preparation of these things. Sometimes we do leukocyte, so many things are there. So we should always consider some remote possibilities in our patient. So my dear friends, this is a summary of my presentation. There are 4 common causes of self-limiting thyrotoxicosis. The most common among these are subacute thyroiditis. Less common, I had told you that acetotoxicosis. I have not mentioned, but some descriptions of palpation thyroiditis by an overzealous student. Drugs I have already shown you. Some hemorrhage into the cells. Very rarely drugs like biotin, nowadays more common, as also sometimes not previously diagnosed Graves spontaneously resolving, causing this condition. Graves causing the inferno pattern, thyroid hell pattern, which is for, again, for completion's sake. Also, sometimes the diffuse hyperplasia type of Graves can also mimic Hashimoto. These are undistinguishable, which is why the morphological pattern, because the follicular hyperplasia type of Graves, experienced pathologists will help you in this regard. So again, the treatment all for this. So when you have a euthyroid patient, you need not have any treatment. Just manage them conservatively. When you have a patient going in for a follow-up hypothyroidism, there is a role for L-thyroxine. So the euthyroid thyroiditis, again, I am repeating, anti-TPO positive, no other conditions, just have to follow up. Otherwise, give a dose of thyroxine, which is therapeutic dose, not the homeopathic or small doses or 12.5 doses. You have to give a good therapeutic dose, because atrophic thyroiditis can occur in the long run if you are not providing proper dosing. Then coming to the corticosteroids, the only role is there in inflammatory conditions, and I have put this because our surgeons sometimes manage these patients and operate this patient. The indications for the surgery for these cases are definitely when you have a mass effect, when nodules are increasing in size, the pressure manifestation, the patient may tell, or surgeon may elicit again suspicion of malignancy, because this is a very serious thing which I will focus in one slide. So malignant transformation of Hashimoto's has been described sometimes, because this is like the egg and the hen hypothesis. So we may not know the exactly which is the first one which happened. So these are 2 relatively common diseases. So the cause and effect relationship needs to be very much taken into the molecular pathophysiology. The relationship, because the chronic inflammation can lead to the long-term neoplastic transformation, like other conditions also. Again, the prolonged effects elevation of TSH may stimulate the follicular epithelial proliferation. These are the 2 pathophysiological reasons where they are describing. First is the chronic inflammation per se leading to the molecular markers being triggered. Second is the chronic elevation of TSH stimulating the follicular epithelial cells. This is the thing which the publications have again shown. When the primary event is the papillary thyroid carcinoma, definitely the history of family we should remember. The micro events will be there. The non-autoimmune thyroid failure may be one of the things. So the radiation exposure, because in some areas there is a radiation exposure is there. In Kerala, we have a coastal belt of exposure to ionic radiations being again exposed. We are hypothesizing there. These areas, all these areas, nodules are there in most of the common patients as well. So in this case, the primary event may be environmental factors. So again, this triggers of we have to check the molecular markers like RET proto-oncogene, the BRAF mutations. So these are very much available. I am sure that in Bengal, we have a literature from Sujay Ghosh sir's library. We have so many studies published very recently. Also, some good publication had come. The point mutations are good in this case in the genetic screening. So in this case, the accumulation of lymphocytes can lead to development of immune response to tumor. So other side, we have the indolent phase. That is the primary event was the Hashimoto's toxicosis, Hashimoto's disease. So the genetic background may be missed in some cases. But here I have told you the loss of tolerance of the T cells. So the B cells, T cells. So autoreactive lymphocytes within the thyroid diffusely accumulating, leading to the full-fledged autoimmune reaction. So the autoimmune molecular markers like CTL, the tumor markers, all these cells are triggers, cytokines, the NF-kappa, so many triggers are there. So finally, the oncogene expression, the P69 is the one described in this case, leading to the advanced stage of papillary carcinoma. So at least 1 to 2% have been described, because longitudinal case studies have picked up very high rates. But I am sure that publications are not to be believed. We should see the long-term meta-analysis and data, which again maybe in the future we'll have. So I am just putting the last slide here as the surgeon's point of view. This patient may be an advanced 48-year-old euthyroid Hashimoto's disease, persisting symptoms. In their textbook, because I have taken this from a recent publication, showing in the guidelines, they have mentioned the total thyroidectomy, one of the indications in Hashimoto disease. So we should know vigilant about all the guidelines, including the surgical guideline, because when we say that it is not to be given, but still they are mentioning in their guideline a Markov decision pathway, right? The complications, all these things they have mentioned. So they have given a score of depression, quality of life for symptomatic depression. So many things are there, which is why we should be always looking beyond our guidelines also. So again, the learning pearls, which I think I should summarize, are there should be a good lab having a quality control with the good trained clinician and the sonologist also. And we should have a good experienced pathologist doing more frequent FNACs in our hospital. Adequate history taking is never a substitute for anything. Even the best of labs, adequate history taking is one of the cornerstones. Assay interferences, various drugs, biotin, heparin, so many drugs you already know are interfering. So this is one of the things which we have to remember. Heterophile antibodies, macro TSH, you all know this, just that's why I have not put this. Consider the remote possibilities. Some patient iatrogenic taking extra dose of thyroxine by itself, some nutraceutical containing, we know armored thyroid, many other drugs having thyroid-like action. So again, routinely measuring autoantibody is not indicated, but we know that receptor antibody can have a stimulating pattern as well as the blocking pattern. So any patient having Hashimoto can further go into the long-term reason, like behave like Graves, because this antibody pattern can change from the stimulating to the blocking pattern. So I have shown every conditions which I am sure we all be exposed in the common clinical practice. So again, thank you, the organizers. I think I have tried to put in most of the topics. I have tried to cover the recent updates. If I have made any mistakes, please free to point out. So thank you. And these are the books I have referred to. Thank you very much.
Thank you, Dr. Mohan. So that was a wonderful and a very exhaustive presentation. So you did cover all aspects of thyroiditis, not only subacute thyroiditis, but there are various other forms of thyroiditis, and you have covered all of it. So if there are any comments from the organizers, or if the students want to ask any questions, please feel free to ask.
Saptarshi?
Yeah.
Yeah, thanks, Mohan, for your exhaustive, comprehensive view of the topic. There are a few points I want you to comment on. First is there is a prevalent in gynecologic and infertility expert practice in primary or unexplained infertility. If the TPO antibody is high, whether the patient is euthyroid or hypothyroid or on replacement, we get requests for corticosteroid therapy, whether that's going to help so far as thyroid is concerned, so far as fertility is concerned. What's your take on that?
Yes, sir. So TPO positivity and subclinical hypothyroid, there are many literature. The basic publication is from the Negro et al. Literature. So JC in 2012 also there are very good literature had come. So they had mentioned that anti-TPO positivity, TSH more than 4 is one of the major things which we have to start thyroid, and otherwise we have to follow them up. Anti-TPO, how far positive we have no clue, because very strong, more than 100, just a positive, a good assay, which we always go by. And corticosteroids are not indicated in any case except for a postpartum thyroiditis, because that is only one of the conditions which we use steroids in the patient, not during the pregnancy. or even a prevention of thyroiditis, we don't do because we have easy request because only antibody is positive. Please do something. So executive checkups. Yeah, somebody does the antibody positive. It's come very high. So please treat the thyroid. So I just apologize because we don't get any steroids for those.
Another, Rahul, please mute others who are not speaking. And another, actually, this was a difficult patient of mine, who actually visited me at an interval of around 8 or 9 years. And the total duration of her course was probably 16 of his course. He was at the last visit around a 60-year-old gentleman. A course of around 15-20 years with 3 episodes of thyrotoxicosis, which was presumably due to thyroiditis. So then he wanted a definitive therapy because he said, okay, it's not bothering, but then doing the tests too often, once I'm becoming euthyroid, then again thyrotoxic. So why can't we think of any ablative therapy? Actually, then I looked up the literature and discussed with others, and I had offered him an ablative therapy at a point of time when he was euthyroid with a high dose radioiodine, just to make him predictably hypothyroid and kill the issue. And he since then has been on replacement, levothyroxine replacement, with now a stable hypothyroid, replaced hypothyroid course, not the yo-yo one. What's your take on such rare?
Yes, sir. Yes, sir. Yes, sir. I agree, sir. Some patients have these problems because nowadays we know long-term thyroid, because there is a case report of micropapillary carcinoma developing. So how you are monitoring, because some patient doesn't turn up for a follow-up on 3 years time. Suddenly, if you have a nodule and now you are telling it's FNAC showing a papillary carcinoma thyroid, that's also you are caught, because medico-legally, if somebody tells, if you knew it was a problem, why didn't you go for it? So I was checking this. No guidelines have told anything about all these things. And also, as you told clearly, radioiodine is not indicated. But if patient is hell-bent upon this, if you want a cure, because surgery is one thing which we don't prefer, but then that's what, if you have a very small dose iodine. So how much dose did you give, sir? How many curies?
I don't remember, because since we irradiated him at a point of time when he was euthyroid, not hyperthyroid, so I gave him 15 millicuries so as to make him predictably hypothyroid.
Only one dose was required, no, sir?
One dose was required.
And finally it turned into hypothyroid.
Hypothyroid, now he is happy on replacement.
So that's what hypothyroid is more easy to us, for us to manage also. My teacher, Dr. R.V. Jayakumar sir, used to tell, if you make him into the other side, you actually are saved, because anyone can manage him now. So otherwise they come and eat our clinic also.
Right. That's true. I think Saptarshi, now you can go ahead with some of the questions.
So I think there is a question which was asked by Dr. Pankaj. Lady with thyrotoxic feature detected 3 months back with goiter, technetium uptake 6%, high FT4 at diagnosis, started with neomacazole 10 mg in 3 months, tapered down to 2.5 mg. So can it be resolving subacute thyroiditis?
So it's a Graves-like presentation. So I think the Hashimoto thyroiditis, that's hashitoxicosis. That is one thing which is also to be considered, because in this situation, resolving SAT won't have this, because SAT will always have a low uptake. Also, one case report, when I am a student still in Amrita, we had a case of low uptake Graves also. The Graves uptake was low. So possibilities are numerous, but I think in this case, free T4 is high. The uptake is a bit higher. Looks like a Graves-like presentation. So resolving SAT is not possible.
So again, a question from Dr. Raja Paul. So after starting steroids, is there any interference with the antibody tests?
Not at all, not at all, not much of an interference. They are just mentioned very small, but I think steroid also we usually use very small dose only, because unlike the inflammatory, because the one condition which we use, which thankfully no question has come, Hashimoto encephalopathy, because steroid reversible encephalopathy was described, but it's not the same as thyroiditis. So in those cases, we used to have a high requirement of steroid, but otherwise, usually steroids don't interfere with any antibody test as such, at least to my knowledge.
So I think Mohan, I will just, maybe the time is running out, so it's already 9. So I will like to make just 1-2 brief comments. So one is, so for the student, so how do you clinically, so if somebody comes with a picture of elevated T3, elevated T4 and a suppressed TSH, so what are the clinical features and what tests will you order to differentiate between? So that is the most common practical differential we have in our day-to-day clinic practice. So whether it's silent thyroiditis, so if there is pain and all, obviously it points more to subacute thyroiditis. So how do you differentiate between a silent or subacute thyroiditis versus Graves' disease? So clinical features and tests.
That's what. There is also something called T3 T4 ratio, free T4 index. So many things are there. But clinically, the subacute will have this pain, and the lady will be more of a toxic initially only. But if you give a follow-up frequency about 2 weeks, 3 weeks, that it will slowly get resolved. So the Graves picture will be typical. We have that the staring appearance, the nodules will also be there sometimes, and also we have tremor, and the sympathetic overactivity will be very typical in the Graves disease. Very more striking in this Graves. The orbitopathy is one of the major things which picks up. The triad of Graves is definitely, you know, orbitopathy, the pretrial eczema, and the goiter. So all these things are to be kept in mind. And you know, the quantum of elevation of T3 T4, definitely it is more for the Graves, and as time goes, we know that Graves will need a definitive therapy. So that is why we should establish a diagnosis by the technetium uptake. The technetium uptake will help you once you have done with the clinical and the biochemistry, and when you have a clear-cut picture in your mind, because we don't go for the, without any picture, we don't go for the nuclear scan. And one more thing, always rule out pregnancy, because pregnancy is one thing which can be missed, because the lady may not tell you all these things. So when you have a picture, when your lady is confessing she's unmarried, then still you may be right in going for a beta HCG by the blood, at least serum. I have done that in my practice, to just say, because before going for the nuclear scan, I have done sometimes beta HCG also.
Mohan, just to summarize what you said, differentiating between thyroiditis and Graves' disease in the absence of goiter and orbitopathy or dermopathy would be the severity and the duration of the disease. Thyroiditis is less severe and the duration is less, whereas, of course, there would be overlaps, you may be befooled, but generally the severity and duration would be clinical clues to whether you are dealing with Graves or a thyroiditis.
So if it's a serious symptom, prolonged duration, weight loss for 6 months, 4 months, so 99% chance it will be Graves' disease, unless we are there are some cases of confounding factors. And again, examination of the thyroid gland can also be helpful. So you can we will have a more diffuse enlargement of the thyroid in Graves' disease. In subacute thyroiditis or silent thyroiditis, there can be nodules. Their local position might vary from time to time. Sometimes you have a nodule on the left side. After 2 weeks, you examine, you can have it on the right side also. And also, if you if for the exam for the students, it's very important. The examiner will want to hear it from you that you need to also auscultate the thyroid. So if there is a bruit, so there is a chance. These are exam questions, so it's not maybe not that relevant in clinical practice. So if there is a bruit, that points towards Graves. If there is absence of bruit, so it does not rule out Graves definitely. But if you get a bruit, so it points towards Graves. And again, so you can get a thyroid scan. You can get a radioiodine scan uptake also to see what is the so what is the uptake like. In most of the cases, logistically, thyroid scan, technetium scan is easier. Radioiodine uptake, the person might have to come back after 24 hours for the repeat scan. So that becomes a logistic challenge for in a private setup at least. And sometimes if you are not very clear that whether if you are not sure that pregnancy can be ruled out, you can also ask for a TSH receptor antibody. So if the antibody is positive, that suggests that the possibility of Graves' disease, and if it's negative, it's most probably thyroiditis. I think if there are any other questions, I will request if in any of the panel audience.
One doubt, sir, Nilanjan sir, in your institution, how much is the Hashimoto's? Do you have any picture of a percentage of hypothyroid having Hashimoto's? I was searching. Have you done any audit, sir?
We do not have data, but you mean to say that how many patients of hypothyroidism have DPU antibody positivity? That's the easiest way.
That's
to Hashimoto's. I think we are not keeping the data, but I think it is, if you do it, it is quite significant, maybe around 30 to 40%, at least for my private patients where I do the TSH DPU antibody routinely in all patients. So high titer positivity is maybe around 30%, 1/3 of patients.
And have you found assay variations also? Because nowadays assay variations, because antibody test, sometimes they have some assays may not be properly done also.
Yeah,
so
that problem is always there. You have to do it from a reputed laboratory. We are following that. But the point is that until and unless you are dealing with subclinical hypothyroidism, your treatment generally does, or in CTTT, that is chronic thyroiditis and transient thyrotoxicosis, actually antibody titer is not actually going to make any difference as far as the treatment is concerned. That way, it's easy that way.
Thank you.
So Dr. Mohan, maybe the last question.
It's a pleasure, sir. I think I was very fortunate to be among the.
So very rarely, sometimes we see a patient who have typical features of thyroiditis, but is euthyroid on biochemical examination. So do you get to say cases of euthyroid subacute thyroiditis?
Yeah, euthyroid is not that much, sir, because sometimes you don't get TSH will be sometimes low. Most often will be low.
But again, it's reported. So if you
it's reported. Maybe I have not seen.
If you have the classic picture of subacute thyroiditis, even though if you have a strong suspicion, you can still get a thyroid scan done. And sometimes you see that only one lobe is affected. It's inflammation of one lobe, and maybe the other lobe is functioning normally. That is why so maybe the thyrotoxic burden is not that much. So that is why the thyroid function test is normal. So in any other questions?
Saptarshi actually commenting on what we do get to see. I also do get to see. Why Mohan doesn't get to see? Because many a time the patients come to us because of symptoms or because of an abnormal thyroid function test.
Yes.
So it depends upon how much thyroid function test your colleagues are doing and sending the patients with an abnormal thyroid function test.
Referral bias, sir. Referral has to be.
It's a bias of that. So since many of my colleagues do it, I do get to say, C, absolutely asymptomatic, but with with no goiter even, but with odd thyroid function test, which subsides over 3 months' time or so, and you do a TPU antibody that's also maybe high. So we do get to say being referred from other specialists, mainly notably gynecologists probably. That's okay. I think Saptarshi, it's time for you to wind up.
So I think we had an excellent presentation by Dr. Mohan and very important inputs from Dr. Sengupta as well. So I would like to again congratulate the Endocrine Society of Bengal for their continuing education activity, and also would like to thank all the viewers who have joined, have taken out time today. And again, thanks from my side to all the organizers, Dr. Nilanjan, Dr. Rahul, Dr. Shomik. So thank you, and we'll again hope to connect, hopefully physically sometime with many such more academic programs. Thank you.
Thank you, Saptarshi sir, and thank you, Mohan sir, for the interactive session. We thoroughly enjoyed it. I thank all the participants for joining. Before we close, I would like to announce that on 29th of October, we'll have our next session, which will be on hypophysitis. The speakers again from Kerala, Dr. Praveen VP from Amrita Institute, Kochi, and our chairperson will be Motoshi Roy Chaudhary, madam. And I also like to wish all of you a happy Durga Puja. Enjoy your holidays and be safe. Thank you, and we'll close the session.
Thank you, sir. Thank you, everybody. Thank you, Rahul. Good night.
Good night.